So just a quick background. Really what we're trying to do is we know that the nurses are still having trouble answering the sepsis BPA alerts. I also know that when we do targeted education, we see really huge improvements with how they respond to the alerts, which would translate then into how well we identify these patients and how quickly we can get treatment for them. And so we did a pilot at Henry where Dr. Evans did some really quick BPA education for the nurses on 3 South. And I've looked at the data pre and post that intervention, and they were able to realize over an 80% reduction in the total number of alerts that they see. And so essentially what's happening is when nurses don't understand how to interface with the BPA, they hit that cancel button or that dismiss button, and then every time the nurse opens the chart, it fires again. And that is a self-created type of alert fatigue that we're now seeing. And it's really frustrating for the nurse too, because they don't know how to respond to it, they don't know what to do with it. But once they have clear understanding, they seem to do better. And so we were just brainstorming with the sepsis core team about a month ago, and also there's been 2 RCAs related to sepsis and our failure to detect it early, and in both of those instances the patient unfortunately died. And so we wanted to find a way that we could help our nurses to better understand how to interface with the BPA. And the idea came that since we now have APP coverage at Atlanta, Fayette, Noonan, and Henry, that you all are really in a good position to help us with this. And so the ask for you all on the call, and of course you can get your colleagues to help you out as well, is to do what I'm thinking will take about 15 minutes, maybe 20 if there's a lot of questions, in services with nurses. So at the nurses station, you can advertise it and say, hey, at 12 o'clock we're going to huddle for 15 minutes. However you see easiest to get this accomplished. And I want you all to target critical care and ED nurses first, and then our plan is, and the kind of the thought behind that is you already have a relationship with nurses in critical care, and you probably have or are building relationships with nurses in the ED since we pick up patients from there. So we thought this would be a good bridge. And then for the acute care floors, we're going to utilize our STAT teams in those locations to do education, the same education, with acute care nurses. So does that sound okay to everyone so far?
Yep.
Yeah.
Yes.
Okay, excellent. So also in that invite is a roster. It's just a blanket Excel spreadsheet. And what we're trying to go for is 70% of staff being educated by the end of this month. And if it takes longer, it takes longer. But that's our goal. So as you do these in-services, I just want you to keep up with a roster. And it's got all the information that I need on there, the nurse's name, I think their employee number, where they work, and the date they had the education. And that way we can just have some way to track how much of an impact we've had. So again, we'll do this pilot till the end of the month and roll into March if we need to, or if we're finding that it's really helpful, we might extend it as well. So after today, I'm giving you all the permission to then just go forth and conquer, really is what I'm asking you to do. So I sent you 2 different, I think I sent you 2 different PowerPoints, maybe not. The one I've got in the room today for the folks at Piedmont Atlanta is just a PDF version. If you've got the PowerPoint version, there's note slides or notes at the bottom of each slide, which gives you all the talking points that go with the slide. So now what I want to do is just briefly run through what those talking points are, kind of how the education would look, and then I want you all to ask me questions that you have or might have or think that the nurses might have about the process, so that we make sure that we're sending the same message to all of our nurses across the system. Okay?
Cool.
So some of these slides you all have seen before. I've taught sepsis, I think, to all of you, or at least you've been to a lunch and learn. And so this first slide is one that you've all seen. It's just really highlighting that sepsis is common, it's dangerous, it accounts for half of our inpatient mortality. And you can go through these if you want to with the nurses, but it's not necessary to go through every line. What I tend to highlight on this slide is that half of the patients are identified in the ED, and that's where our sepsis program started. But we also know that sepsis is also diagnosed or can be found on the inpatient side, and that's why we focus heavily outside of the ED as well. And that really the best way to find these patients and the best way to prevent them from dying is to identify them early and to begin treatment early. And along with this, would be good to mention on this slide or somewhere in the presentation that the updated Surviving Sepsis Campaign guidelines, which came out just a couple of weeks ago, one of their new recommendations, it's the very first one actually, says that sepsis is an emergency and should be treated as such. I want nurses and providers and physicians and everyone to begin to think of a positive sepsis screen the same way that they would respond to a code stroke, a code STEMI, or a code blue. It's really that much of an emergency because we know that these patients can linger for weeks before they get really sick and potentially die, or they can go from 0 to 60 in a matter of hours. And so just really identifying them early and treating early is kind of what we're trying to get to. So it's an emergency. The next slide is just a review of SEERS criteria. I realized doing nursing education last year that we give in the BPA what the alterations to SEERS to the vital signs are, but often they don't even know what the SEERS criteria are. And so we still base our sepsis screen on SEERS criteria, and so this is just a review of what those are. And what SEERS is, you all know this, it's not specific. It can mean a lot of different things. The next slide is what's called the Altered Mental Status Best Practice Advisory, or BPA. Nurses will ask you what a BPA is, so just let them know it's Best Practice Advisory. I was shocked that we didn't know what that was, but they don't know what it is. Lots of people don't know what a BPA is. So just going over that. This Altered Mental Status BPA fires once the patient is admitted to the hospital, so it doesn't fire in the ED at all, and it fires every 8 hours after that. And it's asking the nurse to identify if there's been a change in neurostatus for that patient. We know that altered mental status is one of the SEERS criteria, and this currently is the way that we're capturing it. You don't have to share this with them, but we're going to probably remove this and rely on nursing documentation, but that's going to take probably a couple of weeks to a month to launch that, so stick with this BPA alert, and if it changes, I'll give you all a slide deck that's updated with the new process. And I always mention on this slide that this is organic altered mental status. It's not altered mental status because they're on a propofol drip, right? So it's altered mental status coming from within the patient. The next slide just reviews organ dysfunction. Again, nurses, I don't believe, know what the criteria are, so just to have it for them, that these are the criteria that are showing us that the patient is hypoperfused. And again, these are only relevant if they are an acute condition. So it would be important to highlight two of the examples that I use most often are patients who have chronic renal disease or who are on HD and have a baseline creatinine of 5. If their creatinine is 5, that's not an acute change. And so if you see that in a BPA, you have to start putting those pieces together. At Piedmont Atlanta, we do a transplant, so a bilirubin of 12 on a transplant patient, pre-transplant patient, is probably their baseline. And so again, putting those pieces together to look for what is the acute change for this patient. The next slide is the first of the BPAs, and the easiest way to explain this is that the BPA is really, the orange BPA is really telling the nurse that the patient meets SEERS criteria. So 2 of those SEERS criteria are positive, and that's why this alert is firing. What this alert is asking the nurse to do is to think about, is the elevation in heart rate and the hyperthermia because of an infection, or is it because of some other reason? And I used the example of, I chose those 2 parameters because I used the example of the immediate post-op patient who's having a normal, in quotes, rebound hyperthermia to anesthesia, and they're tachycardic because they're in pain or they got up out of bed for the first time. So again, it's really critically thinking about the patient and the context of what they're seeing. I think I have it on here, but if I don't, there's actually a lot of notes to this page. But some of the things that I tell them to do is if this BPA alert fires and it's based on vital signs that are older than 2 hours, it might be worth going to recollect vital signs. Again, there's all kinds of, patients might have an elevated heart rate for a few minutes and might come back down, or a couple of hours. Patients are not the same 24 hours a day. So really trying to assess the patient to really find out what's going on. If they know, and I've got a couple of things highlighted, the first box that's highlighted shows the nurse what the parameters were that caused the BPA to fire. So in this example, it's that elevated heart rate and a temperature of 102. And then at the bottom, I have in a square the responses that the nurse can give. I want you to steer them away from the already on sepsis protocol button. We're going to remove that probably at the same time that we remove the altered mental status BPA. But I really want them to think about when they see this BPA to answer the question either yes or no. Either they have a new or worsening infection or they don't. So if they're already being treated, just the answer would be no. Does that make sense? So really to answer it, we want them to answer yes or no within 3 times of seeing this thing fire. So as an example, I come on shift, I've never seen this patient before, I open the chart because I'm looking for something, a lab value, a note from the previous shift, and this BPA fires. I can't answer it because I haven't assessed my patient yet, I don't know what their history is. So that's when the nurse would hit the dismiss button, is I see it, but I need more information to answer it. So I'm going to dismiss it. I'm going to go into the room, I'm going to reassess my patient, I'm going to look at the progress notes, I'm going to look at vital sign trends over time, I'm going to do something to assess what's going on if I don't know. And then when I go back into the chart, because I hit dismiss, it'll fire again, and then I will hopefully at that point be able to answer the question. Because you're going to be targeting education to just critical care and ED, the orange alerts are handled by either the attending or whoever's on service in the moment. So for those 2 groups of nurses, there's really no reason for them to get stat team involved at this point. On the acute care floors, we would want them to call stat team for orange and red alerts. But in critical care and ICU, we feel like the orange alert is less severe. We usually have a provider in that vicinity that can help us answer this and get order started if necessary. Questions about that alert? All right, the red alert is, of course, that's the patient who's much sicker. And what that is really indicating to the nurse is not only do you meet Sears criteria, but now your patient also has evidence of organ dysfunction. And so again, we've got 2 boxes highlighted here. The first box, again, is the Sears criteria. The bottom box are lab values that would indicate organ dysfunction. And the way the buttonology works is the same. So if yes, this clinical criteria is evidence of an infectious process going on, then they would click yes. If not, and they can explain it from some other reason, then they would click no. When they hit that no button, on the next slide I'll show you, there's a place where they can write a comment that says why it's not. So, the creatinine is 5, but this patient is on HD and their baseline creatinine is 5, or whatever the reason might be. With a red alert in the ED and critical care, we want them to notify the stat team. Critical care nurses, as you all probably have figured out, don't like to call the stat team. I don't want to force them to call the stat team, but I try to sell it as they're there as a resource to help you. So, it's nice if they do. If you all feel like, and now that we've got you all placed in all of these ICUs around the system, that's probably not as necessary, but that was the initial intent, was to call the stat team for additional resources. In the ED, it's more pertinent for them to call the stat team because ED nurses are not really trained to monitor CVP and mixed venous gases if you do decide to put in a central line and use those 2 things for your 6-hour bundle monitoring. So just know that those nurses, they're not really trained and equipped to do that kind of long-term kind of monitoring. And that's where the stat team can come and help you get that mixed venous gas sample sent for the first one and get the CVP set up going for that patient if that's what you decide to do for that patient. Questions about that particular BPA? Okay, the next slide shows the bottom of the BPA, and in critical care and in the ICU, the nurse is empowered and has been approved by MEC that they can open the order set and initiate treatment before they make the phone call. And that's kind of what we would want them to do. And again, that's where the stat team can really come into play, is they can start all of this stuff while the nurse is calling, or vice versa. And so that's where that extra resource comes in. But for the ICU and the ED nurses, they can click on that open order set button, and then on the next page is just a screenshot of the initial orders. And what the nurse is allowed to order from this is what's pre-checked, and it's essentially a lactate, blood cultures, CBC, a CMP, PT, PTT, INR, and a 500 ml fluid bolus. So if the patient requires that 30 ml per kg fluid bolus, you all would have to come back and order that along with the appropriate anti-infectives for the source of infection that you all see, or think that it is. All right.